we have a wonderful panel today, and the format will be I'm going to just spend 2 minutes to set up the stage, and then we'll allow each panelist to introduce themselves, and then tell them tell us their perspective and their work, and then I'll have a few questions to ask around. After that, we'll open to the floor for the audience questions. Health disparities is a issue that has been around for a long time. But when I started looking into the health disparity last year, that I found out there's actually it's not well known. Few people actually really pay attention to it. And this is one of the purposes that we're having a panel today, is to look at, and also particularly to take a fresh look of the health disparity. And according to the government's report, the report from HHS and other agencies, that in the last decade we have not made any good progress in health disparity, and that's the status today. And so, to me, I'm asking myself, I'm from industry, so I'm asking myself, well, there must be a problem there, and so we're going to ask about what the problem is and how to address it. And the traditional way to look at health disparity is looking at the racial disparities or along the socio-economic and lines, but that's not what we're going to actually focus on. We're going to focus more on the technology angle as well as the social innovation angles, and look at what are the solutions to actually technology solution to solve the problem. And the health. I want to give you one of example of healthcare disparity that I'm talking about. For example, in chronic hepatitis, there are only less than 30% of the patients are being tested and treated as recommended by CDC. That means we are missing 70% of those patients, about 5 million Americans in our country that are not getting recommended care. And that's kind of the one angle that you can look at the disparity. And there's a lot of other way that you can look at it. Disparity can be in even health IT disparity, meaning in the underserved population, we have much less resources in terms of information systems, and also in the when we talk about the treatments for the underserved population, we have much less. The treatment are much less affordable. So what are the solutions to make treatment more affordable is also something that we want to talk about today. And so that's the background that I want to set up first. And now let me introduce our first panelist, and then go along the line. So Sophia Chen from California Healthcare Foundation, and she's the director for the Better Chronic Care, and California Healthcare Foundation has done tremendous work in a lot of areas. So we'll let Sophie to tell us more.
Good afternoon. Are you asleep yet after lunch? I'm just going to introduce a little bit briefly. I'm sorry that I missed the morning, but I think one of the themes that came out was the frustration that we often have with diffusion of innovation in healthcare in particular. And I'm actually channeling my colleague Margaret Laws, who's in Detroit right now, and in terms of our work that we're doing in our innovation fund. From my perspective, I'm a physician. A lot of my work at the Healthcare Foundation has been about better models of care, showing how you can do it better, showing the impact, knowing how to model it, sharing it with others, and with the kind of continual difficulty and having the adoption actually happen. Our CEO, Mark Smith, is also an MBA, and so we probably amongst foundations have perhaps a little bit more of a business perspective on how to do things as opposed to a standard philanthropic perspective. And so one of the things we're experimenting with is something called the Innovation Fund. It's a $10 million fund that we'll be spending over the next 3 years. And it sits in this kind of funny place between kind of standard venture capital and actual true investment in existing companies. The belief here is that we have funded some of the most impressive pilots across the country, often in academic centers where we can show a fabulous model. The money goes away, the model goes away. And so the bet here is to say, if we actually start out with people who are thinking about business and spread and adoption as part of how they do things, can we potentially have a different impact? So we are looking for, as part of our innovation fund, technologies and or services that are actually going to impact 100,000 lives or save $25 million in costs, specifically in what we call the underserved population in California. So it's looking at things differently. It's interesting, we partner a lot with other venture capitalists, actually angel investors as well, who see some interesting technologies or interesting things which, from a standard VC perspective, is not necessarily going to get the kind of ROI that they're looking for, but they also see what the social impact might be, and maybe this is something we would be interested in. And so, Margaret, if you go to chcf.org, Innovation Fund, you'll find it. The criteria are there. We have we've been seeing a lot of very interesting emerging companies. I guess the other point I want to make is that a lot of what we have is frankly what we pay for, and I assume that this is kind of what came up earlier in some of the conversation. And so many of us, whether or not we think that healthcare reform is going to happen or not, realize on the healthcare delivery side that things have to be done differently. And frankly, we have to start saving a lot more cost. There is an incredible amount of waste. I actually just came from a meeting in Boston 2 weeks ago where even the doyens at Harvard Medical School were admitting that we kind of overtreat people sometimes, right? So in that context, though, I think there is a shift. There's a cultural shift happening, finally, I would say, on the medical profession side in terms of taking more stewardship of how we use our healthcare resources. And I think part of what we have to get out of is the trap of thinking, quote, there isn't enough money in the system, and that is why certain populations are not getting sufficient care. That is why they're not getting access, etc. So I'll stop.
That's great.
That was great.
All right, Lisa. Lisa Hammann is the Senior Director of Access Solution Operations at Genentech. And it's a big pharma biotech company. And they have they're also done a fabulous job in terms of how to make the treatment more affordable to the patients. Lisa?
Thanks. A plug for the Innovation Fund. It's truly awesome. It's really an exciting thing, so please do look it up. So, hello everyone. Yes, I am Big Pharma. Everybody loves me in the healthcare system. But I do have the best job ever. I run our patient assistance and reimbursement support infrastructure at Genentech. And what I want to do is spend my 2 minutes describing to you what we have, why we have it, and what we're doing, and what I need in terms of technology, because as I spent some time at the SVForum, I realized I am the buyer. I'm the customer. So Genentech wants to buy stuff from the people in this room, and so this is an opportunity for me to tell you what I'd like you to invent. I see the healthcare system in the U.S. as having kind of three big issues: complexity, underinsured people, and uninsured people. And in Access Solutions, we solve those problems in relatively simple ways. We provide comprehensive benefits investigations for patients and practices and physicians for whom the complexity just overwhelms them. We will call health insurance companies and sit on hold for a really, really long time and probe to say, really, what is that out-of-pocket cost you say this person has? If the person has a really, really big out-of-pocket cost, the second thing we do is help them with their underinsurance, which is we send them to copay assistance foundations around the country to whom we donate into therapeutic areas. So what that means is that we give money to a foundation for any patient with breast cancer, not just a Herceptin patient, or any patient with rheumatoid arthritis, not just a Rituxan patient. And we triage these patients to these copay assistance foundations so that they can handle out-of-pocket costs when the costs are too great. And the third thing we do is we also have a foundation, the Genentech Access to Care Foundation, that donates free medicine to anybody who makes $100,000 or less and has a FDA-approved indicated need and doesn't have health insurance. So we were just talking about the safety net. We are a safety net to a certain extent for our patients around the complexity of the system, the fact that they may be underinsured, which of course then leads to odd behaviors, right? And that means 5 to 10% of your income you're paying for health care, which means you do potentially the wrong thing in your choices, and of course the uninsured population. What I need from technology there is the ability to scale those kinds of services as demand increases for a massive pipeline that I've got to somehow cover, and a healthcare system that can't handle my pipeline. So think about it. I can't hire another 10,000 people to do this kind of thing for the patients that are ultimately going to need it. And so I need scalability of the ability to deliver these kinds of services to patients. We have a call center in San Francisco right now with a couple hundred employees, and it can't triple in the next 3 years. And so I've got a real business problem that I need people in this room to solve there. The second safety net-ish thing that we're working on now is reaching more on a global basis with emerging economies throughout the Roche affiliate group. So I was just in China meeting with colleagues of mine from India and Indonesia and Russia and South Africa to say, how are you serving underserved patient populations in your countries? Not everyone can build a call center. Or develop their own foundation and send free medicine to anybody that needs it, right? That doesn't exist in Indonesia, that has no private healthcare system or public healthcare system. There just isn't a system. So one of the other things that I need is good ideas about how could a company like Roche provide services and safety net type of programming to patients in other countries that right now have nothing, so that if you have breast cancer, you can get Herceptin. And so that's the next round of things that we need and things that we're thinking about at Genentech.
Thank you, Lisa. That's great. And our next panelist is Cassie Kim, the professor in residence from San Francisco State University. And she's working on some exciting projects that applying technology to reduce health disparity. Kim?
Great. Hi. I spent 12 years working in healthcare provider organizations, so hospitals and medical groups. And so I saw the problems of actually trying to impact care of patients from the first, not from a clinician standpoint, but from a business standpoint, how you run organizations that try to serve patients. And then I moved into technology and delivered 3 products to the market, the first one being with our medical group, but then 2 more being venture funded. So I was an entrepreneur, so that was my second decade. And then a couple years ago, I said, enough of this. I'm just going to go study it. Much easier. And teach about it. So I came back to the university, and I actually do research in health IT. So you just heard what a big pharma wants from you. So I'm going to tell you how I can help you as technology people. I think there's a lot of information that as researchers we have that can actually help you develop products and to develop business models that are appropriate. So the example I'm going to give is my current study, which is funded by the Robert Wood Johnson Foundation, where we partnered with a company, thecarrot.com, to customize an application for youth with obesity and depression. These are all low-income youth in San Francisco. It's a population that definitely suffers from health disparities, but if you look at the issues that health disparities are really focused on, they're the same issues as the rest of the population. Obesity, heart disease, diabetes, asthma. The reason to focus on populations that have health disparities is that you think systematically about what are the things in the system that are broken. Because health disparities are not just differences between populations, they're differences that are a result of structural problems, systematic problems, socioeconomic systems. So it helps you identify where the pain points are that you can address. We actually showed in our pilot study, which we had 2 cohorts. So in our pilot study on the first cohort, we actually demonstrated improvement in health outcomes for this population. So we had 34 patients in the first cohort, 21 in the second. We demonstrated health outcomes and improvement in patient activation levels for this population. So the other lessons that you can learn are, why did this work when most types of mobile intervention, most interventions that have been studied show very minimal sorts of impacts, and often they're not statistically significant. So why does it work? Research helps you understand why. And part of what we think worked was that we built the technology into a care delivery model that could actually be sustained with using health coaches and a school health clinic. It wouldn't require a lot of additional investment in infrastructure to actually maintain what we've already accomplished in the pilot study. So we've uncovered a lot about what works, and for a technology company to say, okay, I can see how this works in a delivery model, I can see who to sell this to, I can see who benefits from it, and why it can actually impact the business of my customers, then we think that's valuable information. So we hope you can take those kinds of lessons from us. I think the other area that I would hope we can talk about in our discussion is what sorts of patients actually benefit from the use of technologies. And I know this morning was very focused on sort of the business aspects of the healthcare delivery system and impacting efficiency and cost savings and those kinds of things. But I think a lot of that doesn't actually get accomplished unless you can engage patients in being true partners in their care and in the management of the resources in the healthcare industry. But we have somehow this idea in the technology world that we should just build these apps, and someone said this morning 27,000 applications. I think there are actually 40,000 now health and fitness applications available across all platforms. That somehow we should build all these things and put them out there, and if they're free or really low cost, everyone's going to adopt them, and then suddenly we're all going to be healthy. Health disparities and health has not changed since the advent of the internet. We still have the same problems we did in 1996 when the browser came out. So clearly that's not enough. And I think the issue is that we're not targeting the right kinds of peoples with the right tools that they can actually take advantage of them. And so that's another area that I'm really interested in, which is a concept called technology activation, so that you as technology developers and entrepreneurs can understand who's going to benefit from your technology rather than just putting it out and hoping someone's going to pay for it eventually. So I'm looking forward to the rest of the discussion.
Great, Cassie. Now, our fourth panelist is the Vineet Singal, a student from Stanford, and he's one of the great examples of how the young generation, and particularly students at the university, are in fact looking into this into solutions to solve the health disparity problem. Vineet.
Hi everyone, my name is Vineet. I am a senior in Stanford, graduating in a month. Kind of scary. About 2 years ago, I founded an organization based upon my experience working about 3,000 hours at free clinics in Texas and California. I'd taken time off from Stanford to do something that really mattered to me and my family. And my work with this organization called Anjna, it's named after my mom, is specifically designed to create a health technology company that is not for profit, that is sustainable, and that is focused on improving health outcomes for individuals from low-income backgrounds. And that sounds like everything that we have just talked about, but the way we're going to do it and the way I think we're going to make it happen is through partnering and really working alongside with low-income health settings like free clinics and sliding scale clinics. And so the model that we're working on specifically is creating health education programs that are specifically designed to work directly with doctors, but realize the realities that exist in a free clinic model. So there's one example that I often give when I talk about Anjna, which is specifically a mental health clinic in Oakland that serves about 600 patients every week. And the physicians there spend about 5 to 10 minutes with each patient because they're seeing about 40, 50 patients every day. And that's the reality that we're facing. That's what we're fighting against. When you have a severely depressed individual or someone with schizophrenia, and they're coming into a clinic and they're being given 5 minutes and they're being given a prescription and being kicked out, that's what we're trying to fight against. And health literacy and health education are so incredibly important because when we can catch things early, and we can maintain and we can improve disease management and we can prevent complications from arising, we can save astronomical amount of dollars. Just one example is a case of anxiety. Mild anxiety, when prevented, can save the healthcare system about $21,000 per patient. And so that's the goal of Anjna, is to use technology like tablet computers that are situated at waiting room kiosks and exam room kiosks, and then text messaging applications that send patients reminders about taking medication and meeting future appointments and rescheduling in partnership with Medic Mobile, which was funded by the California Healthcare Foundation. And so that is something that we're looking at very closely. And this idea of scaling, I mean, we're a company, so we're always thinking about scaling and always thinking about what potential partners, whether it be pharmaceutical companies, insurance companies, that we can look at so that we can provide this service to low-income settings for a very, very low cost or even for free, while at the same time maintaining our own sustainable future. And so we have partnerships with several hospitals and clinics in the area, and I can talk about that. And I would love to talk to any of you about what I just talked about and see if there's interest in working together. Thank you.
That's great. So now let's look back. I'm going to start just a few questions, and let's look back and see what are the successful approaches we have, has been used in our country in this area for fighting a for healthcare disparity, and either in hospital or in any other settings. And Sophia, can you start with that?
Big question. There are a couple models. If you think about it from a kind of system delivery side, I think there's some interesting things that have happened, for example, in the VA healthcare system. So if you take for granted that everyone has some type of coverage and you really put an emphasis on quality, you actually wind up narrowing disparities. So I actually had been at the VA before I came to the California Healthcare Foundation, and we found that especially when you're working with providers, you can't go to them and say, you're providing discriminatory care. Doesn't resonate, doesn't engage, doesn't really enable you to try to narrow that gap. I think where it does enable you to say is, let's sit down and let's figure out how you can do a better job in taking care of your patients. And in doing that, you start raising the common bar. And often when you do that, you start narrowing. And in particular then, if you still find that there are differences, and they've been doing this at Kaiser now for some time, within population subgroups between me as a doctor and an African American man or a white woman, we can actually delve into that a little bit more and figure out how is it that I'm communicating. So that's a very kind of nitty-gritty on-the-ground thing. In terms of how do technologies actually enable this, a lot of what we're finding is that the myth of the digital divide is really a myth, especially in many of our public health settings. So I work at San Francisco General Hospital, and everyone there says, oh, no, our patients don't do that. They do. They have cell phones. They may not have smartphones, but they text message. I had a patient the other day, and I kind of literally lost him in the hospital. I'm madly texting him, coming back, I forgot to give you something. There he was. So, I mean, we kind of take for granted that they're simple technologies that can be used quickly, easily, without a lot of new bells, whistles, or frankly costs that could markedly improve our ability to provide care.
That's great. Yeah, Lisa, what have you seen in terms of serving the underserved population?
Sure. I mean, I can share my own experience again from my space. So we have all kinds of examples of physicians not offering medicines to patients because they don't think they can pay for them. And our position at Genentech is, if it's right and it's appropriate, you should have the choice. And the two things that get in the way are this expectation about, well, they can't pay for it, so I'm not even going to bring it up because what a heartbreaking experience. And so part of the reason we have the services we have is not just to meet the needs of the patients that truly need it, but to also help physicians understand that it doesn't matter. You should ask every time, because we've got you, right? So that's part of it. The second thing is it's inconvenient. What I have to fill out for the Medicare whatever, or the 16 different prior authorizations or whatever, is just too much. And my practice does not have 5 people in their billing office to really get it done. And so technology can also make that simpler. If you're able to say, no, you don't have to fill out the button, e-signature, you're done. That would be dreamy, because then the hassle factor would also be taken away. So there's a kind of take away the fear, give them confidence, take away the hassle, make it convenient. And at that point, the patients who do make it into a physician's office, which is a whole different discussion, are more likely to get access to the things that they need.
That's great. Cassie?
Yeah, now I get to profile my own project, which is called In Touch. It was funded by Robert Wood Johnson Foundation, part of Project Health Design. And this portfolio of projects that are now just finishing this spring were all designed to use mobile technology to engage patients in self-tracking, basically, observations of daily living, but to integrate that into a clinical workflow. So our project, we're all youth, 13 to 24 years old, all low income. We had 50% Latino, 25% African American, and then 50% Latino Hispanic, 25% African American, and then 25% Asian Pacific Islander Native American. We used the application from thecarrot.com. We customized a couple of the trackers. So they did food, exercise, mood, and socializing, because these are teens who are also at risk for depression. We implemented it with a health coach. So what the research tells you is that mobile technology or computer applications, which were the first version of sort of consumer engaged health, don't work unless you have this feedback loop, unless you are getting not just putting information in, but getting some feedback from the system. Whether it is an automated system or whether it's the actual clinicians or some other sort of health workers, there has to be some feedback. There has to be a relationship. Otherwise, it doesn't get you a lot of impact. So we used a lay health coach who was actually stationed at the high school wellness center and then had other appointments at the hospital clinics as well. What we found is that these, all of our participants were, as I said, low-income youth. Not a single one of them had a smartphone. Most of them had cell phones, but from month to month they were either on or off depending on whether they could pay the bill that month, and so their numbers changed constantly. Many of them didn't have home phone numbers, or when you called them, they no longer lived there. And so trying to engage with these patients from the hospital was almost impossible. They could never find them. It was easier at this high school because they were actually within a school that they came to most days, not all the time, but they came there on a regular basis, and so you could engage with them easier. One of the things that we discovered is the engagement with the technology was a no-brainer. They had no issue with a little bit of orientation. They picked it up. They knew how to use it. They liked using it. There was just no barrier in terms of that. We know that's going to be different depending on the age group and the complexity of the kind of engagement you're trying to have. But for this application, very easy to use. They liked it. They got it. No problems there. But does that turn into actual changes in health, which maybe the venture capitalists that were here earlier said that was not the key driver in terms of getting funded. But I think for the healthcare system overall, for foundations, for the public health, for government payers, that is a key question. Does that yield then health? And what we found is that it can. Our participants had significant reductions in waist circumference, which for youth, overweight youth, that is the key driver. It's not weight loss and it's not BMI readings. It is waist circumference because that's a measure of fitness. And the surprising thing is they got increases in patient activation levels. Patient activation is their confidence, their belief, their ability to actually impact their health. And that's something that hopefully lasts and has a ripple effect on everything else in their health. So if you can improve their actual physical health and you can improve their ability to impact their health, then you've got a recipe for actually impacting a health disparity. I would also argue that you have a recipe that impacts the general health as well, although we haven't demonstrated that. So I think, can it be done with something, as simple as a mobile application, which, by the way, we run on an iPod Touch, so there's no data plan needed. It's run through Wi-Fi. We got the school to open up their Wi-Fi, give our students the password so they could actually record while they were at school. And when they left the study, they kept the iPod, and many of them are actually still doing it, even though they're out of the study, which we were kind of excited to see. We only get to track them through the end of May, so we don't know what happens after May, but many who ended 6 months ago are still using it. But it's a sustainable technology. They can keep the iPod. They don't have to pay a service plan, and they can keep going with it. So we think that mobile technology can be a very useful tool to address health disparities, but if it's implemented in a way that actually works in the care delivery system. right? So they get feedback, they meet with a health coach on a regular basis, which for some of them was once a month. Some people came in every 2 weeks, some people came in once at the beginning of 6 months and then didn't show up until the end of the 6 months, but they have different ways that they want to engage. The last thing that I want to say is that the other key thing that we learned here was that the reason that this is a health disparity intervention is that we address the structural problem. So what's the structural problem among low-income youth? It is access to primary care services. Not because of lack of insurance. Everyone pretty much had Medi-Cal in our population. They have the insurance, but they don't feel welcome into the healthcare environment. They don't want to go to the hospital to get primary care, which is where they're supposed to go because that's their medical home. It's a clinic within a hospital. It's not easy to get to. It's not a friendly environment. So they don't go. Even these ones that are sick, they don't go. So we actually gave them a way to engage with the healthcare environment that they liked. So they were asking their health coach about, should I get an appointment? Can you help me get an appointment? Where they wouldn't show up for appointments in the past. We had them asking, can you help me get an appointment at the hospital? So it's a way to address that structural issue that then has, as I said, this ripple effect on the rest of their health because you've given them a resource that they didn't have before. And so we think it's a really positive finding.
It's great, a great innovation there. So before I open up to the floor, let Vineet also share his experience.
Sure. So one of my advisors at Stanford, his name is Robert Sapolsky, and his research is really cool. He has done research in Kenya on baboons, and the research specifically shows that baboons have hierarchy, right? So you have the top alpha male, and then you have hierarchy, second, third, fourth, at the very bottom. And what he showed was that stress levels in baboon hierarchy are the highest in the individual baboons that are at the bottom of the hierarchy. And then they go linearly up. So the guy at the top has the lowest stress levels. And then there was this researcher in England who worked at who studied a company, a multinational company. And he studied the similar thing, stress levels in individuals who were at the entry level all the way up to the CEO of the company, this multinational company. And he showed the same exact pattern. That the person at the very bottom, the person who was an entry-level employee, had the highest stress levels, and the CEO had the lowest, and the same thing correlated for blood pressure, for all the different health outcomes. And so they studied that, and what they discovered was that this was specifically a result not of anything related to their job or the kind of work that they did, but it was related to the level of autonomy that they felt they had in their job, the level of freedom that they had in decisions that they could make. And so and this is extremely tragic, but individuals who are at the bottom half of our country, individuals, the have-nots of our society, those are individuals who do not have a lot of autonomy. And this has specifically been related to lower health outcomes. And so the research that was just described by Kathy, I think it's an example of individuals who feel like they have a structural social support and they have some level of autonomy in their own healthcare. And so the work that we're doing is kind of very similar to that, because what we're trying to do is we're trying to create a very, how many people are engineers here? Engineers, awesome. So you know what I'm talking about when I say a closed loop system, right? A closed loop system with an afferent and efferent loop. And the afferent loop is when the patient comes into a clinic or a patient comes into a hospital, we have this application set up for them in the waiting room or in the exam room that's interactive, that's fun, that's gamified, all of that stuff. And that asks them, what can we help you with? So the person says, I'm feeling kind of sad, I'm feeling like I am gaining weight, whatever. They give us some data, they give us some information. And then what this application is doing is, or how we're programming it to do, is create targeted health education information that is specifically the efferent loop that goes back and gives them that targeted information in the language of their choice, and it's culturally relevant, all of that stuff. And so what that does is that it provides them with a structural social support that's saying that this application and the people who created it care about me enough that not only are they giving me this information that's relevant to me, but they're also offering to send me text messages, and they're also offering to send me information afterwards and keep me, like the health coach, keep me informed and have some sort of feedback loop. And at the same time, it's giving them more autonomy because it's telling them, look, you can do this. This is not something that is hard or it's out of your control. It's something that you can have autonomy and you can have control over.
Great. I guess now it's time to open up to the floor for any questions. Go ahead.
Yeah, I have a question for Sophia or Chen. You said now you changed the funding target to the business startup rather than the university.
No. Let me just clarify. So the question is asking whether the foundation had changed our funding targets to business in lieu of universities. No, we still have our standard portfolio. The innovation fund is an experimental fund, which is a small part of our overall portfolio. We're still doing work with the community clinics across the entire state to improve the patient experience. I'm still working with the public hospitals across the state to implement palliative care teams, to improve the quality of the care that they provide, et cetera. So this is just a different experiment to try and figure out are there other ways of trying to more rapidly disseminate change?
Questions there?
Good question.
You just wait for the microphone.
I can talk.
Great. Shout it.
With the innovation fund, are you understanding what you already said, what you were looking for, are you working with really early stage companies? I mean, what's your sweet spot?
You can't be that early stage if you think that you can show me how you're going to impact 100,000 patients and save $25 million to the healthcare delivery system. We aren't doing early prototypes. These are fledgling companies, frankly, and we will invest in both for-profits as well as revenue-generating not-for-profits. So these are usually things that have been up and running and are really trying to figure out how to scale. And many of them are scaling in the commercial market, and part of what we do is help bring it into the safety net market. Go to the website. I mean, it's kind of hard because I don't run the fund, and I'm afraid if I say something I may not be quite correct. So go to the website, and it's all there. Thank you.
What's the website to check?
Just go to, it's innovation/chcf.org, or if you just go to California Healthcare Foundation, chcf.org, and in our search box, find Innovation Fund, you'll get right to it.
Any more question? There's a one there.
Mm-hmm.
And I know that's such a costly part of our healthcare system.
Yes.
A lot of people end up in emergency rooms and we need to and whatever.
Yes.
Are there things that you're seeing where you can partner with maybe technology companies, whether it's software, hardware, whatever, that ensures that patients are taking their medication properly, and be able to, help fund that part of the cycle?
We spend gallons of money on persistence and compliance programs. Yeah, just sort of historically. We at Genentech are somewhat new to that because we're a biologics company first and foremost, and small molecules are somewhat new to us. But yes, that's a very well-funded part of our business. And in fact, there are moments where my operation actually participates in those things. Unfortunately, I can't speak to the specific newest and greatest and latest, but I'm relatively sure that whatever is new and latest and greatest, we're buying.
All right, go ahead.
For Katherine. Can you tell us a little bit about, so you finished the pilot, had great results, and now you need to scale. And how are you going to do that? And if there's something someone in the audience who can help you.
Yeah, we'll pass around a hat, and you would each put in $100. So we did the first pilot. Yeah, go talk to Sophia.
That's right.
We did the first cohort, which we finished in the fall. We finished yesterday a second cohort, and Holly Logan, who's our project manager in the back row, was instrumental in getting that done. So we've now got data on a second cohort, and our plan is to expand it. The part that I forgot to mention was that we also integrated the data with electronic health record. So that was the link to the physicians, and there was some conversation earlier about getting all the data on an ongoing basis to the physicians, and they really don't want it. What they wanted was a one-page summary that they could glance at before the patient visit, and that's what we provide to them, and it's in their electronic health record so they can see it before the visit. But the health coaches get all the data, so they can actually scroll through and see everything. But in terms of scaling it, so we're a university, and so our financing model is get another grant. So we'd like to get another grant to expand it because both the high school and the hospital were really pleased with the outcome of this. And we need to move from a pilot of 55 patients, to a project of several hundred patients to really demonstrate its efficacy on a larger scale, and to try and address cost effectiveness. I mean, there are other projects that, even in the public hospital, have led to funding changes by the Department of Public Health. So a previous health coaching project with an adult population had good results, and the Public Health Department funded permanent health coaching positions based on that. So we'd like to scale to that point where we can get the Public Health Department to fund them for the youth. But the other is to find other ways to make it a structural change, whether it is a private payer, whether it is a government funding agency, or whether it becomes a cost that a hospital is willing to put forth. We'd like to explore all of those things, but we feel like we have to go one more stage to actually get there. I think scaling of the technology and the reporting and the actual model of engaging with health coaches, that we understand how to do. It's really it's systematizing the funding relationship that we need to be able to address in the next project.
Take one last question for the rest of the time.
Thank you. I have a general question for the panel, and that is, even with the private medical facilities, I was just at one last night, and they all treat themselves, or they're all acute centers, even for the private ones where private health insurance will pay for. So one of the things that I see as a red tape as well, having visited a family member there, is, okay, we can only hold you for 2 days to kind of give you some treatment, some counseling, but that's only like half an hour tops. After that, work with your health insurance provider to see who can help you here or there. So when you're talking about also stress levels, which is, it always goes down the food chain in terms of what you can delegate to other people, how and who will take responsibility or can have that position to work the full cycle so that it becomes easier? Because I see the cost also in the lost opportunities, whether it's in the actual dollars or the lack of follow-through, because again, it's a lot of red tape and they can't follow through with family counseling or whatever it may be.
Yeah, that's one of the things we actually tried to address. And I think because I come from the provider world first and then into technology, when we started our study, we actually thought through the whole delivery model. And we said, okay, we have youth who have weight issues and they are at risk for depression. And so what do we do when they exhibit signs of depression? And the hospital actually didn't have a mechanism in place, so they created one. They created a way to refer to short-term therapy, to a psychiatric social worker, and to the urgent care counselors. So there was a mechanism to deal with that. At the high school, they just didn't have the resources to do it, but they have their on-site social work interns and those kinds of folks. So we actually asked all those questions before we even started, because we need to know how this is going to get dealt with. Even though that's not the subject of our study, we are actually intervening in people's health here. So we need to make sure that we understand how that's going to happen.
So the larger hope, which hangs eternal at this point, are the two concepts of the patient-centered medical home and the accountable care organization. So the bottom line is as I mentioned earlier, we kind of get what we pay for, and we pay for widgets and we pay for services. And we don't pay for continuity, and we don't pay for consistency, and we don't pay for things that fall through the cracks, essentially. So what's happening is hospitals are now potentially going to be dinged for patients that get readmitted within 30 days. So now they're thinking a little bit more beyond the discharge. Just a little, 30 days, right? You've got primary care docs who now are saying, ooh, I'm going to be incentivized and I'm now a little bit more responsible for making sure that when someone goes from point A to point B that I know about it and that there's a plan of care that covers them. So we're trying to create those mechanisms to fill those gaps. This is a huge place as well where communication and technology can make a tremendous difference. We just invested in a company that's doing some work around hospital discharge to avoid readmission. Putting a lot of these communication pieces into the hands of patients in particular and their families is huge. Go to Mayo. Go to Mayo and see what it's like. You go there and a nice lady comes in, or a nice person comes and says, hi, I'm your nurse navigator. I'm here to help you through your entire system here. Boy, if we could all afford Mayo and get that, we'd all be flying there, right? So what are the elements of that could actually be automated? So we don't need a physical person, but where there's a mechanism to know that person is going from point A to point B, who needs to know about it, who needs to be aware, how can you find them? Even give them a GPS so they can know how to get from point A to point B. I was just at a hospital this morning where I couldn't even figure out where the main hospital building was. And so this is a common thing that we all experience either as patients or as family members. And so, you know, even as a technologist, or for me as kind of more of a policy person trying to, just put yourself in the patient's shoes for a few minutes. Strip away kind of a lot of what you are thinking about in your, quote, professional life. We realize when you do that how disempowered patients are. And some of the key tools, I think, for empowering them, allowing them to become more self-efficacious, et cetera, is to simply give them their own information in their own hands. And I think there is a lot of work on the federal side trying to say, great, you have an electronic medical record hospital system. That has to be available to patients. It's their data. So I'll stop.
Vineet has something to add.
So I will second every single word that was just said, because that's absolutely true. And Dr. Chang is hits the nail right on the head, because information is power, and accurate information that is targeted and made available and made engaging and made user-friendly is really important. That's kind of what we're doing. So at Stanford, there's this thing called the Design School. It's also known as the D School. And we worked with one of their professors on a mini research study at a free clinic. And we had 2 prototypes of the application that we were building at the time for individuals with depression. And so these were 2, I guess, cohorts, but these were, very small user groups. The first group had both were newly diagnosed with depression, and the first group, the psychiatrist at the clinic said that you should go see a therapist, and that's all that was said. And the general practitioner said you should go see a therapist, or the person who diagnosed with the depression said you should go see a therapist. The second cohort said the same thing. You should go see a therapist. You have depression. Take whatever medication. Go see a therapist. And we had an application right there that showed them on Google Maps. So this was very simple, very user friendly, but also very scrappy. The directions from the clinic to the actual therapist center. And we found that every single person who was given those directions actually did go to the therapist and did actually do the therapist session. So we said, that's something that we can integrate in our application. But that's just an example of how giving information and making it easy and all those things are just so important. And those are some of the things that we're emphasizing in our work.
All right, I guess we are running out of time already. Let's thank the panelists all together.